Welcome, I'm the dentist. In our Dent Agenda, we will be continuing the first chapter, History Taking and Examination, Part 5, Radiography. In this tutorial, we will discuss the second part of radiography, extraoral radiographs. These are the points included in this chapter video series. And here is the detailed content. In this tutorial, we will discuss extraoral radiographs. Radiology. Why do we need to use extraoral radiographs? They can be used to examine large anatomical areas, to study the growth and the development of the skull and dentition, to detect any fractures or pathology, to detect any lesions, to detect impacted teeth, and to evaluate temporomandibular disorders, to plan the treatment for the dental implants or any other prosthetic appliances. Extraoral radiographs can substitute intraoral radiographs in case of patients who can't open their mouth, handicapped patients, or patients with trismus or temporomandibular disorders that cannot tolerate the placement of intraoral image receptors. Note that they can be used alone or in conjunction with intraoral radiographs. Before we dive into details, you need to know some basic information about skull planes and lines. The three planes that are present in the skull are, firstly, the mid-sagittal plane or the sagittal plane. It passes through the interproximal areas of the incisors and through the nasal septum and nasal bridge. It divides the skull into two symmetrical halves, right and left. The second is the coronal plane. It is perpendicular to the mid-sagittal plane and it divides the skull into a front and a back parts. The third one is the transverse plane. It passes through the skull horizontally and it divides it to an upper and lower parts. Moving to the lines. The first line that you need as a guide in the extraoral radiographs is the canthomietal line. It passes through the outer canthus of the eye and to the external auditory meatus. The second one is the Frankfurt line, or the infraorbital meatal line. It passes through the lowermost point of the lower rim of the orbit and to the external auditory meatus. The third one is the mentomeatus line. It passes through the mental point of the mandible and to the external auditory meatus. In this tutorial, you'll be able to learn all about and differentiate between these 10 types of extraoral radiographs used in dentistry. Number 1. Posterior anterior or occipito-frontal view. This view is a non-angled radiograph of the skull, meaning that the X-ray tube or the tube of the X-ray source is being placed horizontally without any angulations. It provides an overview of the entire skull. It is used to assess the mandible and to assess any medial or lateral displacements of the skull fractures and to locate any neoplastic changes or diseases. As you can see, the image receptor is placed in front of the patient and it will be perpendicular to the mid-sagittal plane and it will be parallel to the coronal plane at the same time. The central X-ray beam will be perpendicular to the image receptor at a 0 degrees angulation. It is directed from the posterior to the anterior of the patient, hence the name postero-anterior. It is parallel to the patient's mid-sagittal plane and at the level of the bridge of the nose. The patient's position: you should make sure that the nose and the forehead are touching the image receptor or the cassette. The canthomietal line will form a 10-degree angle with the horizontal plane, and the Frankfurt plane will be perpendicular to the image receptor. And here is the receptor size and the exposure dose in kilovolt peak and milliampere seconds. Here is the posterior-anterior view, where you can see the mandible vividly to detect any abnormalities. Number 2, the Caldwell view, or the angled posterior-anterior or posterior-anterior axial view, and also called the orbit view. This is actually an angled radiograph. It can be used to visualize the paranasal sinuses, especially the frontal and the maxillary sinuses. You can assess any inflammatory conditions like sinusitis, osteomyelitis, or any sinus polyps or cysts. Also, it is the most useful to detect any fractures in the orbits. That's why it is called the orbit view. The image receptor is placed in front of the patient, and the patient's position is placed as the nose and the chin is touching the screen. Here's the receptor size and the exposure dose for reference. Number 3, the antero-posterior view, or the fronto-occipital. It's a non-angled radiograph. It can be used to assess any medial or lateral displacement of skull fractures and any neoplasm. The image receptor is placed behind the patient, perpendicular to the mid-sagittal plane and parallel to the coronal plane. The patient's position: the patient stands at the back of the head, which is the occipital bone, is placed against to the image receptor. The X-ray beam passes through the patient from the anterior to the posterior part, hence the name antero-posterior. And here's the receptor size and the exposure dose for references. Number 4, town view, or the angled antero-posterior or antero-posterior axial view. Note that the town view is done while the patient closing their mouth. It's an angled antero-posterior radiograph that can be used to evaluate any medial or lateral displacement of skull fractures and any neoplastic changes. The image receptor is placed behind the patient with the nuchal ridge placed against the image receptor, and the Frankfurt line is perpendicular to the receptor, and the X-ray source should travel 30 degrees coded to the Frankfurt line. Here's the receptor size and the exposure dose for reference. Number 5. Reverse town view. To differentiate between this and the last one, town view, the reverse town is done while the patient opening their mouth, and the aim for that is to be able to view the condyles clearly. The image receptor is placed in front of the patient, perpendicular to the mid-sagittal and parallel to the coronal plane. The position is similar to the posterior-anterior, but with an open mouth. The nose to the forehead of the patient should touch the receptor, and the patient head will be tilted downwards so that the canthomietal line will form about 25 to 30 degree angle with the image receptor. And most importantly, the mouth is open. The X-ray beam should be perpendicular to the image receptor. Here's an image to the reverse town projection. It is quite unique because you can see that the skull is elongated because of the open mouth, and the condyles, the necks of the two condyles, are visibly seen. When the clinician requests this image to evaluate the condyles, it is necessary to specify open mouth reverse town. Number 6. Occipito-mental or Waters view. This is an angled posterior-anterior radiograph that can be done with the patient tilting their head slightly upwards. It is indicated to examine the sinuses. The sinuses are normally radiolucent. If there is any case of inflammatory sinusitis, polyps, or malignancy, it can be represented by a thick mucus lining, radiopacity, or destruction in the walls. It can also be used to diagnose default 1, 2, or 3 fractures. The image receptor is placed in front of the patient, perpendicular to the mid-sagittal plane, and the chin should be touching the film. The patient's head should be tipped back so that the base line of the skull forms a 45 degrees to the image receptor and the mentomeatal line perpendicular to the receptor. The X-ray beam should be perpendicular to the receptor, and it passes through the occipital bone, then through the mental area, hence the name occipito-mental, and it is horizontally placed with 0 angle. Here is the receptor size and the exposure dose for references. As you can see, the position of the occipito-mental or Waters view, where the X-ray beam is perpendicular to the image receptor and the baseline of the skull forming 45 degrees on the cassette. And as you can see, frontal and maxillary sinuses are vividly seen. Number 7. The 30-degree occipito-mental. It is just a different angle from the horizontal or 0 angle occipito-mental. It is indicated to diagnose default 1, 2, and 3 fractures and the coronoid process fracture. The image receptor is still in front of the patient, and the patient is placed exactly in the same position as the 0 degree or the horizontal occipitomental with the baseline of the skull, forming 45 degrees to the cassette, and the mentomeatal line is perpendicular to the receptor. The difference here is the position of the X-ray tube. It is not horizontal. Instead, it is 30 degrees above the horizon, and it is centered to pass through the lower border of the orbit. Number 8. Submentovertex, or the base projection. It's an angled infero-superior radiograph of the base of the skull. It is used to assess any pathology in the basal skull structure, including foramen ovale, foramen spinosum, and sphenoid sinuses. Any fractures in the zygomatic arch are detected in this particular view. The image receptor is positioned parallel to the patient's transverse plane and perpendicular to the mid-sagittal and coronal planes. The position of the patient is achieved by the neck being extended as backwards as possible, with the canthomeatal line forming a 10-degree angle with the image receptor. The X-ray beam is perpendicular to the image receptor, and it is directed from below the mandible and towards the vertex of the skull. The beam is centered about 2 centimeters anterior to a line connecting the right and left condyles, and about 4 centimeters inferior to the mandibular mental point. Here is the receptor size and the exposure dose for references. Here is the picture for the submentovertex. You can see the mandible flipped upside down. Know that many of these views can be taken while the patient is in a supine position. Number 9. Cephalometry lateral skull projection. This view shows skeletal, dental, and soft tissue anatomic landmarks, lines and planes and angles, and the distances between those that can be used to generate measurements and to clarify the patient craniofacial morphological features. It is indicated to monitor growth and development, as well as the progress of the treatment, and to specify the occlusion class of the patient. The image receptor is positioned parallel to the patient's mid-sagittal plane, meaning that beside the patient's face. The patient is placed with the left side towards the image receptor, and the X-ray beam is on the right side of the patient, perpendicular to the mid-sagittal plane and to the image receptor, centered on the external auditory meatus. Here is the receptor size for reference. Here is the cephalometry lateral skull view. As you can see, the skeletal structures, the dental structures, and the soft tissue structures are all visible, that you can draw lines and measure the angles and see their relations. Number 10. Panoramic radiography. It is also called DPT, Dental Panoramic Tomograph, or OPG, orthopantomograph. Tomography is a special radiographic technique used to record images and structures located within a selected plane of tissue, while blurring the structures outside that selected plane. You can see a broad view image of the entire dentition, both in the maxilla and the mandible, with the surrounding bone, sinuses and temporomandibular joints, all in a single radiograph. It is useful to see gross pathology, but not as much for subtle changes like early caries. It is indicated to examine large areas of the face and jaws, locating any impacted teeth or retained roots to evaluate trauma, lesions, or any disease in the jaws, and to assess their growth and their development. The image receptor or the cassette and the X-ray tube move in a direction opposite to one another while the patient is seated or stand stationary in position in between. The machine operates with the patient positioned between the X-ray tube and the cassette, and the patient should hold still. Here is the receptor size and exposure dose for reference. The exposure time is usually between 15 to 20 seconds, so it is quite a fast radiographic technique. Panoramic radiograph is the most extraoral radiograph used in dental clinics. It has many advantages, as that it has an increased coverage for a wide anatomical area, reduced patient radiation dose, less time, and it's an easy and simple and comfortable way to take a radiograph, and it also aids in explaining the treatment plan to the patient in an easier way. But it still has many disadvantages, as the image distortion is increased and the sharpness is reduced, overlapping structures of course and the proximal contact areas. Hence that's why it can be used to diagnose interproximal caries. It only images the structure fit in one layer of the image, so any teeth with a labial or lingual tilting will not be imaged well. Superimposition of the structures, as you can see the spinal column, soft tissue shadows that are present can result in an image mimicking a pathology. It is not useful to detect early carious lesion or early periodontal changes or widening. The length of the exposure time for 15 to 20 seconds requires the patient to remain still throughout the exposure cycle, and any movement can result in a hazy image. The cost of the panoramic machine itself is significant. Should always prepare yourself before taking any type of these radiographs. Firstly and most importantly, ask the patient to wear the lead apron and the thyroid collar for protection. And also ask the patient to remove any eyeglasses, jewelry, tongue, lip piercings, and to remove any dental removable appliances. Here is a summary for all the radiographic views to compare. And here is a summary for the patient position and the X-ray tube position for all the techniques. Thank you. Don't forget to subscribe and to turn on notification to reach us easily. And also reach us on Instagram for extra tips and tricks on every video.